It's now my pleasure, and I want to extend a warm welcome to him to introduce our first speaker, Keshav Narain, who is a retina specialist, and he will be talking about what is macular degeneration. He was born in New Delhi, India, and he opened his own clinic called South Bay Retina, and which he has a table up in the back of the room as well, and has been very active practicing working with macular degeneration patients. So if you'd extend a warm welcome and a hand for Dr. Narain.
Hello. Wow, lots of questions. Thank you so much for the nice introduction, and thank you for starting this organization, which I think is so important. Exactly what Mr. Hoffmeyer said is that this is the leading cause of blindness, and yet so many people don't know about it. How is that possible? And so hopefully after this, you will go and tell other people, and we will get some shed light on this very devastating condition. I'll try not to walk in front of my slides, but I will walk around. And we're going to take the questions at the end, and my job is to set the foundation for what really is this disease, what do we know about it. I'm a retina specialist, as Mr. Hoffmeyer had pointed out. Let me see. The specialty of retina exists in large part, I think, because of macular degeneration. It is something that I have a daily opportunity to interact with, is this devastating disease. And if it weren't for many researchers and individuals, we would not have some of the treatments that we do today. So I want to go over first the foundation of macular degeneration. First of all, who is at risk? How does it affect my vision? How is it diagnosed, and what can I do? These are questions that half of you in the room can probably answer. But I know some of you are very good at looking at your own scans, but hopefully I'm going to give you more of a theoretical perspective at this time. So let's start with who's at risk. In the United States, we know that our population is aging. There's a called graying of America as the baby boomers get to this age. So age, as you may guess, is one of the principal risk factors. It is the leading cause of vision loss in individuals over age 60. Doesn't mean that you have to be 60 to get it. It just means that it really gets a lot worse after age 60. We can break the causes of this disease into two big categories. One is genetic or race-based. The other is environmental. The genetic factors have been very completely studied, and after doing much study on this, the realization is that there is a whole lot more out there that we need to find out about. 65% of the people who get macular degeneration tend to be female. If you look around, you'll see that there are more females in general than men after age 60. And that's one of the reasons that you see it in that population, for a variety of different reasons. Then race. When I was in residency, we were always taught that patients who are at highest risk for macular degeneration are going to have blonde hair and blue eyes, and they're going to be very sensitive. That's not always true. We're finding types of macular degeneration that occur in Indians, in Asians, in Japanese, and they're all a little bit different. And with a population like we have in San Jose, we're seeing it from each different race. Now, there tend to be more in certain clusters, but the genetics are very powerful. There is strong evidence that is familial. And there are multiple genes now that enable us to determine what the risk is if we have more advanced macular degeneration. And we'll get into that in emerging technologies. That's a confusing statement. So we'll talk about that in the emerging technologies section. Other factors. So I said genetics were one. Do you want me to stay here? Okay. I'll stay on my podium. You know, I'm so used to being in a retina clinic where I walk from room to room to room. And, okay. High cholesterol, high blood pressure, cardiovascular disease are all risk factors. What does that mean? That means that if we have any of those, our likelihood of developing the wet form of macular degeneration is significantly increased. Smoking, interestingly, increases your risk if you've ever smoked. So, although it's good to stop smoking, having smoked in the past increases your risk for macular degeneration, as it also increases your susceptibility to developing lung cancer with an increased rate on some of the nutrients, and we'll talk about that also. So, bottom line here is that all of these things are health related. It pays to be healthy, but if the genetics are there, you can be really healthy, not smoke, have good cholesterol, good blood pressure, and you can still get macular degeneration. The reason being that there is a strong genetic component. So, macular degeneration, and this is the phonetics, macula is a part of the retina. So when people hear the word macula, they usually associate that, if they've heard of macular degeneration, they'll associate that with macular degeneration. Not always the case. There are some macular diseases that affect the macula, and they are not macular degeneration, and they don't have the same prognosis. So it's important to separate that. And the other disease is macular pucker that you may hear of. So I want to point to the macula, which is here. It's this tiny little region in the eye, in the back of the eye, right in the center of the visual axis. About 5% of the retina is represented in the macula. But it is a very important 5%, as any patient with macular degeneration will tell you. That is the central vision that provides the sharp, detailed vision that allows you to read. It allows you to watch TV and drive. This is where the highest density of light-sensing rods and cone cells are. And this is what the center of the macula looks like. The center of the macula has another name. It's called the fovea. And below is a cartoon with animation that shows the cross-section. So if you were to take the retina and slice it and look at it so that light is coming in from the top going down, this would be the outside of the eyeball. And these various tissues are the critical elements of the retina. This is the choroid, which is bringing oxygen to the retinal pigment epithelial cells. Now, many of you are familiar with hearing the term RPE, and I use that extensively because the RPE cells are very important in the development of macular degeneration, both the dry form and the wet form. So the RPE cells nourish and protect those retinal rods and cones that are at this next layer. Now, what's really amazing about this is that we now have the ability to look at these layers in your eyes using the technology in the office, using the OCT scan. So we can actually look at your eye and tell you there's a problem here, etc. So the one thing I want you to take out of this is that there are many elements to the retina, and RPE is one of the really crucial ones. That's a target for a lot of new therapies, stem cell transplants, etc., that you hear about. And we'll talk about that, but RPE cells, lots of activity there. So, two forms of macular degeneration. There is a dry form, and it's also, you'll hear it referred to as non-exudative or atrophic. And in the dry form, it's a very gradual, progressive degeneration of vision. And by gradual, I mean over a period of months to years. Okay, and that's very, very different than the wet form of macular degeneration. And if somebody has a question about something that I'm saying, just raise your hand, but we're going to try to take the vast majority of the questions at the end of the session. Is that right? Yeah, okay. So, all right, so two forms of macular degeneration. Dry form, which is the form that we see most frequently, represents about 90% of macular degeneration. What is happening in this dry form? That RPE that I was talking about, it breaks down. You get these spots that look like someone took an eraser and just erased the pigment that was there. There are many patterns of dry macular degeneration. One of the key features is the presence of something called a drusen, and that's again another term that you may hear. A drusen does not equal macular degeneration. So if people have drusen, that can be one of the features of macular degeneration, but it doesn't mean that you have it. And so the presence of and what is a drusen? It's a little yellow spot. The problem is if you have a whole lot of yellow spots in the middle of your macula, that becomes very damaging to the retina, and we call that macular degeneration. Wet form. So wet form represents about 10% of the overall macular degeneration. And by wet, that's often a confusing term. By wet, we mean by formation of new blood vessels. And so in a medical sense, it is the development of new blood vessels in the tissue that result in swelling. And this is why we call it wet. The eye it's not a reference to anything externally. A lot of patients hear dry eye and confuse that with dry macular degeneration. There's no association other than as we get older, our eyes do get dry. So the wet form is devastating. The wet form can result in a relatively rapid loss of vision. And rather than over a period of months to years, we're talking weeks. And this is the form that we have the greatest number of treatments available for. So a little comparison of the two. Dry is the most common form, and it sometimes leads to wet. How often? About 10%. That is a very rough number, and we can get better numbers than that now, depending on how a person performs on a variety of other tests. It's a gradual process. In the dry form, develops more rapidly, very rapidly in the wet form. Vision loss is usually less severe in the dry form, although there are many cases of very severe end-stage geographic disease that results in a pretty bad dry macular degeneration vision. With wet AMD, that typical vision loss is much worse. For dry AMD, it's important to know that there is no treatment. So if there's no treatment, then why do we need to examine you? Because there's nothing we can do about it anyway. That's why we're all here today, right? Because we want to be there at the time that the dry converts to wet. And we know that the dry will convert to the wet at a particular frequency in the overall population. We know that there are certain factors now that make you more at risk for having macular degeneration and having the wet form. So we want to monitor the vision. The problem is we can't monitor the vision all the time. So we have to see you sometimes, but give you the tools to be able to help you determine when the wet macular degeneration may be beginning. So again, multiple treatment options for the wet macular degeneration. Really nothing right now for the dry, but the goal is to isolate those patients who are developing the wet form and treat them very early. So what are those signs that we look for? How are you going to know that you have macular degeneration? Now you've been, or a relative, how will you know your relative has a macular degeneration? Sometimes you can't. Oftentimes you can't. And that's the problem. That's where we as the clinicians have to take a look. And this is going to be a big issue because we've found the more frequently you look, the better a patient will do overall. But who wants to come in, every week for an exam? We can't do it. So we have to come up with a system that allows you to come to us and also allows us to check on you periodically. And that's what we're doing now. That will improve, we're hoping. The signs can be in one or both eyes, but they are often one eye first. One eye, it's not as bilaterally symmetric disease as many hereditary retinal dystrophies are. So this is more asymmetric. Patients notice few symptoms in the early stages, and here's the problem, is your good eye compensates for your bad eye. And so until someone covers one side, you don't notice. And this is why so many cases go to the stage of scarring. And then they come in and we say, okay, well, you didn't realize, but your vision went down in your right eye because your left eye was compensating. But when we test them one at a time, we find this. So what do? We look for drusen, and we can stage the type of dry macular degeneration that you have, and that helps us to determine how risky it is for you to get the wet form. That's helpful, so that helps to tell us when to bring you in more frequently. But that still doesn't solve the problem of getting to it as soon as we can. And so that's still an issue that's being dealt with. Some of the other symptoms, we could probably go around the room and talk about some of the symptoms, but color vision is definitely something that patients complain about. Difficulty with recognizing faces. I heard that Brad Pitt has that also, but it's not from macular degeneration. So they require more light. One of the other interesting things that occurs when visual acuity is affected profoundly in both eyes is you may hear your relatives say that they see people or faces, and they're not crazy. The brain does something, we're not sure why, but it is documented, and it's called Charles Bonnet syndrome, that you will substitute your own visual inputs and create the sensation of seeing faces. So they're not crazy. This is something that's been recorded, and it's something to recognize in a patient. Recognize they're not crazy. Don't have your aunt institutionalized because of this. So what are the more subtle signs? The typical patient isn't going to say, I see faces. The subtle signs are distortion. Straight lines appear to be bent. We have a way of trying to measure that on a grid called the Amsler grid, which we have copies of. It's a very simple test, but if you do it, you can determine if there's a loss of central vision, and that's one of the key symptoms. The other symptom, which is an interesting one, is the objects may appear different size, and that has to do with the focal length of the eye changing. And the other feature is that it's a relatively rapid progression, remember. Days to weeks, not months to years. Okay, this is what we want to know. What can we do? So monitor your vision. Monitor your vision, check one eye at a time. Use the Amsler grid. It's not a perfect test. There's a digital version of an Amsler grid for those of you who have smartphones. I think that we're going to probably have better ways for you to monitor your own vision, and that's really where I see things going in the future. And that will help us to catch the wet macular degeneration right at the beginning when it starts. Contact your eye doctor. Look for distortion, wavy lines, and dark spots. Any missing words or letters. The other thing that many patients complain of is difficulty with reading. Even though they can see the 20/40 or 20/70 line, they say it's getting really hard to read. And so that's another symptom of having a loss of that central field. The reading speed decreases. What else can you do? Well, in California, not that many people smoke, but if you do, this is a great reason to stop. Healthy lifestyle. It really is a huge risk factor in smoking. Female smokers have a 5.5 times greater risk of developing AMD than those who don't. And avoid really any of the other kinds of health risk factors that you can. People ask me all the time about sunlight, and this goes against what the vitamin D industry is telling us, that we all need more sun and more vitamin D. I actually don't worry that much about UV light hitting your retina, because your retina is pretty well protected by the cornea and the lens. What I worry more about is just the other wavelengths. There is controversy over whether the blue light has a particularly damaging effect. It's shorter wavelength, higher energy, and can cause more free radical oxidation. So, again, I don't like to give specific kinds of recommendations on that because I don't think there's enough science there to back up one idea being better than another. I recommend wearing sunglasses if you are outside in bright light. I do. But is there science to say that that's going to alter the disease significantly? Not a lot yet. Exercise, stay active and healthy, and maintain healthy weight. Why leafy green vegetables? Why spinach, collard greens? Because they are high in a nutrient called lutein. And we're going to have a whole talk on the nutritional aspects, but I'll touch on this. Lutein and zeaxanthin are two of the carotenoids. So these are things that are they're pigments, and they're found in vegetables. And they're in very high concentration in certain vegetables. And the way they got to realizing that these might be important is it started out with that slide of the retina showing the cells. And they realized that there's a lot of one pigment in those cells. So they said, where in the environment is this coming from? And it turns out there's lots of places, but one of the rich sources of that pigment is a spinach and collard greens. And so they looked at the diets of people with macular degeneration, and in 1998 a study came out that showed that people who consumed a diet that was rich in leafy green vegetables did significantly better. That prompted another study called AREDS-1, in which they looked at specific aspects of what's in those vegetables. And they found that what was common to all of those were some of these antioxidants: vitamin C, vitamin E, beta-carotene, and zinc. And those were the nutrients in the AREDS-1. Let's see, this one just yes. So, vitamin C, E, beta-carotene, and zinc. What do they do for macular degeneration? What do they do for cataract? Do you realize that AREDS actually looked at cataract too? And they didn't see any benefit to taking the vitamins for cataract. But they did for macular degeneration. But was it for all types of macular degeneration? No. And this is the important point. Only for the more advanced did the study show that there was benefit. So this is a very important slide. If there's one slide that I would memorize, it would be this one. Well, that's because I'm a retina specialist. But the 500 milligrams, 400, these are not mega doses. And it's not that more does better. There was a dose escalation arm. And so these are reasonable doses. The 15 milligrams are, of beta-carotene, that it has been changed now. And the reason for that, let's see, is down at the bottom of this slide. When the study was done, it was found in about the second year of the study that the patients who had even a remote history of smoking seemed to be getting lung cancer at a higher frequency. So that's very interesting because that's showing that taking too much of one of these supplements could be a really bad thing, at least for some people. So the recommendation for those individuals was to take them off, and they actually unblinded the study. The AREDS study was done by the National Eye Institute, and they had 5,000 people, so it was one of the best studies done in the last decade in medicine overall. It's a very well done study. They opened it up and said, okay, everybody who has ever smoked who's on the beta carotene, because remember when you go in the study, you don't know whether you're in the treatment arm or the non-treatment, you get a little pill and you have no idea what it is. So they opened it up and said, we're going to stop all of that. So they took it very seriously, and I take it seriously enough to tell my patients that even if you smoked as a teenager for 3 months, consider omitting the beta carotene and substituting lutein. So I take that recommendation strongly. So AREDS 2 came out, and we were really hoping that this fish oil, I think I had a slide on fish oil, we were really hoping that fish oil would do more than it did in this study. It was a disappointment that the high dose or even normal dose of fish oil had no impact. But what it did do is validate some of the data on AREDS 1, which is actually important, and also showed that we could substitute these two nutrients for the beta carotene in those patients who had ever smoked. So what does that mean? Does that mean you should stop the fish oil? If you are taking the fish oil only for the purposes of helping your macular degeneration, then that would mean that. But most people are on a fish oil capsule for cardiovascular benefit, and so I think it's something worth discussing with your doctor. It's something that your internist may have strong feelings about, and I think it may be some individual decision for everybody. So I don't want to say universally that we should be off of it or on it at this point, only that there are secondary benefits. So some other things. There's conflicting data on the relationship between the vitamin E and prostate cancer. So if there's a concern for men, the nutrient, the vitamin E dose can be omitted. It's surprising but true that the zinc was as effective as the other 3 nutrients in AREDS 1. So you could take out the beta carotene, the vitamin C, and the vitamin E, and the zinc arm did pretty well. So zinc doesn't get a lot of credit because you can't, I guess, brand name zinc. It's just, you know, but zinc was pretty powerful. And again, it was a standard dose. It wasn't a mega dose. So the problem with the vitamin E and prostate cancer is that there is sort of back and forth evidence, and that means we really don't know all the answers. So again, discuss with your doctor, and hopefully you will have a ability to improve your risk profile by keeping on some of these. So what can you do to keep your eyes healthy and monitor for macular degeneration? Eye exam with dilation. So every opportunity to get a dilated exam, get one. I know that you go to an optometrist and low vision. I think it's good to look at the retina with dilation. It's covered, and it's covered under your Medicare benefits if you are on Medicare. And really for any patient with macular degeneration, the frequency of exam is typically going to be more than once a year. This is for normal healthy patients. So for a dilated exam, we recommend yearly after age 60, even if you don't have macular degeneration. Was that 10 seconds or 10 minutes?
10 minutes.
Oh, okay.
Or 10 seconds.
I went way over 10 seconds. Okay, so as I said, the detection piece of this needs to get better. And I've seen many patients who came in after the bleeding had been going on for a while, and they didn't want to bother their daughter or their son and tell them that, So I think letting people know that if there is a change in vision, test the vision one eye at a time at home. Okay, diagnostic tests. So at your eye exam, what do I do as a retina specialist? I focus in on here, on the macula. But what is contributory in my decision-making process to how I will handle your macular degeneration depends on your family history, on your medications, your risk profile, your nutrition status, social history. Nutritional history, maybe that should be a separate part of our exam. This is the test that allows us to look at the cross-section of your retina, and you'll probably see this every time you go to your retina specialist, and they'll study it, and they'll look at the last one, and they'll say, okay, this was here, and this was here. This is a normal one, by the way, so this is how they should look. But this is painless. Takes about 2 minutes, less than 1 minute per eye. And with this is very severe macular degeneration. You can see how different that looks. And the science that gets behind how we get those images is incredible, but bottom line is that you're able to see a cross-section, a microscopic cross-section of your eye without having to be even touched. So there's another diagnostic test that we found extremely useful in macular degeneration, and that's microperimetry. Microperimetry gives us a visual map of what you see instead of just the number. The number is nice, but it's not really telling you how damaged the vision is. A patient who measures 20/40, it means they can see that 20/40 letter. It doesn't necessarily mean that they have great vision. This is what shows the difference. So this patient may have 20/40 vision, but they have a big splotch. See the red area? It's kind of small, but the red blotch there, that's where they don't see anything. So they may be able to move their head around, but this allows us to co-locate a point on the retina with this stimulus and determine whether that piece of retina is functional or not. This is very useful to determine whether the macular degeneration advances. So it's a great test. It's something that is more subjective. So patients don't like this because you have to push the button and you have to sort of be alert, and it's, so we don't do it as often. I would like to see it used more. It picks up very subtle changes in the vision. And the changes in the vision sometimes occur before the changes in the blood flow. So we do talk about photos. Photos are a good way of monitoring the retina. And these are photos, kind of hard to see with the light, but these little yellow spots here are the drusen. And when you have many, many drusen, it could be macular degeneration. But probably the gold standard test for determining whether you have wet or dry macular degeneration remains the fluorescein angiogram. So this is invasive because you get a injection of fluorescein dye, and anyone who's had macular degeneration knows and has probably had many of these. But the dye is injected into the hand. The first question people used to ask me was, are you going to inject the dye into your eye? And I said, no. But now I say no, but we might have to inject something else into your eye afterwards. But I will talk a little bit about that. Dilate the pupils, fluorescein dye is injected into the arm, and then you take a series of photographs, and it gives us a lovely image of the retina and the blood flow. And as you can see in this lower photograph, there's this bright spot, and the bright spot represents the leak, or the source of the wet macular degeneration. So we look at this very carefully. There are places, offices in the country where they think that doing an angiogram every single visit on the patient. So every time the patient comes in, they get an angiogram. That is pretty aggressive. I have found that the OCT helps us to eliminate many angiograms, but this remains the gold standard. Okay, just to recap, leading cause of vision loss gradually destroys the macula. Remember, the dry form gradually destroys the macula. Risk factors, distortion, no smoking, eat leafy green veggies, monitor your vision and see your eye doctor. Your doctor may use OCT, microperimetry, photography to diagnose and monitor disease. Usually a combination of all of those. That's the first lecture, and it's just the foundation. The second lecture, we're going to talk about treatments, injections, treatment frequencies, and that sort of thing. So should I take questions now regarding...
There's a few questions. Yeah. You want to ask some questions? We've got a microphone here to pass around. Do that for about 5 minutes. Over here.
You mentioned about smoking.
Yes.
What about secondhand smoking? Does that affect?
The ARED study didn't look at secondhand smoke, but I think that's a good question. I think my answer to someone who is exposed to a lot of secondhand smoke would be to try to reduce that and try to get your partner to stop smoking, because it potentially, depending on the dosage that you're getting, is going to have an impact. However, I can't tell you that the study proved it because they didn't look at that factor. Okay. So I think it's a valid point, and I would agree with stopping the smoking altogether. Yes?
What is the percentage of the younger generation who have macular degeneration, and is there a treatment for them also?
Yes, that's a good question. So what about the younger age, and what can we do if somebody at a younger age has macular degeneration? So it begins with the eye exam to determine, what type of macular degeneration this is. As I mentioned, the most common cause is the age-related macular degeneration, but there are a few other types, and there are some hereditary types of macular degeneration that don't follow the same pattern. So it is uncommon. It is less than 5% of people will get the dry type of macular degeneration before the age of 60, but that doesn't count all the other types. And as you may know, there are lots of other types of macular degeneration besides the age-related. And so it's uncommon, and it's typically not age-related in a young person. So there are other causes of bleeding in the eye, and if we go back to, I do a whole lecture on atypical causes of macular degeneration, but if we go back to the slide that showed the anatomy, anything that irritates that layer in the eye can create new blood vessels. And the way we code it is with the wet macular degeneration code. So part of your diagnosis, unfortunately, lies within the system that encodes you as wet AMD, CNV. You may, in fact, not necessarily, and I have several young patients who don't have a single drusen, who don't have any features of dry or wet macular degeneration, but they have developed the wet form spontaneously. So that's uncommon, but it happens. Yeah.
One more.
Okay, I have a question regarding the actual statistics of this disease. So we know it increases in age, but does it correlate to other type of diseases that have increased dramatically over the last couple of years, like Alzheimer's, diabetes, and other things? Have we seen any dramatic increase?
So are you, so you're saying, is there a disproportionate increase in the frequency of macular degeneration?
Yes, has it gone up over the last 10 years?
Or is it simply just following the age curve? And I don't know the answer to that, okay? But what we're told is that right now that we're following the stats on the overall demographic shift. Okay, so I think within certain subpopulations, there's an explosion of macular degeneration. And then if you look at other areas, they're saying, well, it's about the same. So I think overall, it is not apparent to us as retina specialists, and when we talk at our meetings about this increase, that it's anything more than, the baby boomer generation. Now, could it be that we still haven't picked up the earlier forms, that we're looking at other forms? There's lots more questions, but I don't know exactly.
How does it relate to other countries? I mean, if you look at the US, the statistics, the Western world per se, and then other civilizations, people, is this the same statistics, the same kind of, do you know anything about
So
this?
it follows racial genetic kind of guidelines. So if you look at countries that have in the European descent and blonde hair, blue-eyed countries, they tend to have a higher rate of particularly dry forms of macular degeneration, and that in turn leads to higher wet. We don't see lots of wet macular degeneration in countries like India. When I talk to the retina specialists who practice in India, they see it, but not at the frequencies that they're seeing in Florida, for instance. So it is very regional, and I think that in the US we're seeing it because of our population. Now, I do see a lot in Hispanic population as well, with diabetes as affecting the retina as well. But I have another lecture in, I guess, at the end, and I'm happy to take individual questions in between. And some of your treatment questions we'll go over in the second lecture. Thank you.
That's a good point. Thank you, Dr. Narain.